This is Nazir Habib. I would like to present hyponatremia management overview and guidelines for the management of this very common electrolyte problem, which essentially is a neurological urgency. So today I'd like to identify the symptoms of hyponatremia early on in the presentation of the patient, also determine the etiology of hyponatremia, and identify patients that require urgent treatment as well as ICU admission. And we will review the optimum treatment to reduce complications of the management of hyponatremia. Hyponatremia is the most common electrolyte and accounts for about 20% of hospital admissions. It results in increased length of stays, and the mortality increases very significantly. The risk of readmission to the hospital is also significantly higher, and there is significant morbidity associated with hyponatremia, including falling episodes. In a meta-analysis of 81 studies, which included over 850,000 patients, comparing the mortality in patients with hyponatremia and without hyponatremia, the relative risk of mortality was 2.6. So as you can see, this is a very significant problem, and we have to optimize the management and recognition of the burden of hyponatremia. Hyponatremia clearly increases mortality. If you look at this graph, normal serum sodium 138 to 142, their mortality is 1. As the serum sodium decreases, there is no significant increase in mortality until the serum sodium reaches a range of 128 to 132. Once the serum sodium is less than 127, this is a very significant deviation, and the mortality is 14.4 odds risk. The risk of hyponatremia is quite common, and there are multiple conditions that lead to hyponatremia, and it is important to recognize all of these. Probably the most common reason for a patient to have hyponatremia is what we call dilutional hyponatremia, which includes congestive heart failure and cirrhosis. Another common condition that frequently presents to the hospital is a condition called SIADH, or syndrome of inappropriate ADH secretion. Patients with adrenal insufficiency, hypothyroidism, renal dysfunction, or postoperatively after surgery may also develop hyponatremia, primarily due to increased vasopressin secretion from stress or exhaustion. Selected drugs also cause hyponatremia, such as diuretics, particularly hydrochlorothiazide. Non-steroidals anti-inflammatory cause fluid retention and renal impairment. All opioids can cause hyponatremia. Antidepressants and antipsychotics are particularly important agents that can cause hyponatremia. Anti-cancer agents, antihypertensive agents, and PPIs can also result in hyponatremia. So let us take this case of a 62-year-old female who presents to the emergency room with headaches, nausea, and dizziness for 4 days, and she has unsteady gait. She also has some muscle cramping and muscle fatigue. Her past medical history includes hypertension, and she's currently taking amlodipine 10 milligrams daily. About 3 weeks prior to admission, she was prescribed citalopram for her depression, 20 milligrams a day. In the emergency room, routine chemistry showed that her serum sodium was 120 and her BUN is 10. Her serum osmolarity was calculated to be 250 and blood sugar was 140. Her CBC is normal, her chest x-ray is normal, and her CT scan of the brain is normal. The first question that comes up is, what is the next step in the diagnosis and management of this patient? The first thing we have to get used to is ordering urine labs. Without this very important step, we cannot manage this patient any further. As you can see, her urine sodium is excessively high, greater than 20. In her case, the urine sodium is 85. And her urine osmolarity is also similarly extremely high, 635. Her TSH is also checked, and her serum cortisol is also checked, which were negative. The urine indices in this particular case confirm that the patient has syndrome of inappropriate ADH, and therefore she should be managed appropriately. The worst case scenario in this situation would be to give this patient IV normal saline in the emergency with the hope of correcting her serum sodium, which is not possible as she is excreting sodium into her urine, and she will retain the water from the IV saline, which will further lower her serum sodium by at least 1 to 2 points. So let us take a look at hyponatremia and how do we approach hyponatremia. When you see a patient with hyponatremia, the first thing you must ask yourself, is this a hyperosmolar state? Namely, does the patient have increased glucose, TKA, or hyperosmolar state? There may be other situations such as a myeloma, increased protein, or increased triglyceride that may also cause hyponatremia. You have to correct the patient's serum sodium in a hyperosmolar state based on the blood sugar. Serum sodium should be increased 1.2 for every increase in blood sugar up to 400, and 2 if the blood sugar is over 400. I generally use a correction factor of 1.8 in a patient with hyperosmolar state to obtain the corrected sodium level. So in this case, the patient's serum sugar is normal. So we then have to ask ourselves what exactly is going on, and we get to hypoosmolar hyponatremia as the patient's blood sugar is only 140. As I've mentioned, there are 2 things that we need to look at. The first is the BUN. Next thing we must look at is the urine osmolarity and the urine sodium, as we have obtained in this particular case. So looking at this excluded now in our patient hypertonic hyponatremia from hyperglycemia, mannitol, or radiocontrast agent. The patient also does not have isotonic hyponatremia from elevated proteins or triglycerides or chylomicrons. So this patient now has hypotonic hyponatremia. The next question is, what is her volume status? If the patient is hypervolemic or in edematous situation, we call that dilutional hyponatremia, and this patient does not have congestive heart failure, end-stage liver disease, nephrotic syndrome, or end-stage kidney disease. So we have ruled out a dilutional state. In this situation, hyponatremia should be treated with Lasix. The patient could be hypovolemic, or in other words, volume depleted. It is very important to notice that in a hypovolemic patient, the serum BUN is greater than 20 usually. If the urine sodium is less than 10, it indicates the patient is dehydrated and avidly retaining sodium, which is very appropriate. This can, of course, also happen with diarrhea and vomiting. If the patient's urine sodium is more than 20 and their BUN is elevated above 20, then it's possible that the patient has taken excessive diuretics, ACE inhibitors, or may have another nephropathy, or indeed cerebral salt wasting syndrome, which is also a very important diagnosis. Once you have excluded volume depletion and dilutional state, you are left with this very important category that the patient is indeed euvolemic, and the patient has most likely serum of inappropriate ADH secretion. This can also happen in postoperative hyponatremia, where the ADH levels are elevated for at least 3 days after surgery. We must rule out hypothyroidism, so obtain a TSH level. Must get a history of possible psychogenic polydipsia, which is quite common recently with many patients drinking up to 3 gallons of water when they exercise. In this situation, the urine osmolarity would be less than plasma osmolarity. Another common condition which we will review is beer potomania, because the patient is taking in a lot of water and alcohol actually increases ADH secretion and blocks water excretion. There can be idiosyncratic drug reaction, which essentially cause SIADH, which includes very commonly the thiazide diuretics and also ACE inhibitors. Sometimes one sees patients with marathon runners or endurance exercise where they may be taking a lot of water, but the ADH levels are very high and they develop exercise-induced hyponatremia. And of course, adrenal insufficiency should also be searched for with a serum cortisol level. So let us think about the symptoms of hyponatremia. We often ignore the fact that in early hyponatremia, in the first 24-48 hours, the patient may just present with nausea and headaches and muscle cramps and fatigue. And I often get a history that the patient is unsteady and they're at risk of falling, especially elderly patients. This is because the patient is developing cerebral edema. You are not going to see the cerebral edema on the CAT scan, but the patient is starting to get cerebral edema from hyponatremia. As the hyponatremia progresses and the serum sodium falls below 120 or thereabouts, the patient will develop vomiting, confused, decreased level of consciousness, and indeed progress to seizures or coma. And I have seen many patients with hyponatremia that will mimic a stroke syndrome with severe myopathy and inability to walk. The first most important issue in a patient with hyponatremia in this kind of situation is to get a good drug history. Many drugs cause SIADH. Currently, probably the most common drugs that cause SIADH are the antidepressants, SSRIs and SNRIs and tricyclics. Usually the hyponatremia occurs in the first 3 weeks. Other medications should be searched for, including over-the-counter nonsteroidals, prescriptions for opioids, oral hypoglycemics, antihypertensives, including amlodipine, which this patient is taking, as well as ACE inhibitors and ARBs. PPIs, including the omeprazole, has been reported to cause SIADH and hyponatremia. The next drug, which is probably the most common drug that causes SIADH type of syndrome other than the antidepressants, is hydrochlorothiazide. Ecstasy can cause severe hyponatremia, and a drug history should be taken. Oncological agents, including Cytoxan, vincristine, and then, of course, alcohol. And remember, Haldol can cause severe hyponatremia as well as seizures. So please avoid the use of Haldol in a delirious patient or a patient who is agitated from hyponatremia. When we look at the risk of hyponatremia from antidepressants, this was a large Danish data bank published in 2016, where they found that 11% of patients with hyponatremia were taking antidepressants. This included a database of over 70,000 patients. As you can see, these antidepressant agents have a very high incident rate ratio of developing hyponatremia. So again, this is very important to recognize that these drugs do cause hyponatremia. So what is the treatment? What I have found is that many times we resort to giving IV saline in the hope that it will correct hyponatremia. Well, in most cases, you would be wrong. In the only situation that IV saline will help a patient to improve the serum sodium is when they're clearly volume depleted. So if the patient has a history of diarrhea, vomiting, taking diuretics, and the BUN is elevated, or they have a contraction alkalosis, so check the serum bicarbonate, then one would give IV saline to correct the volume depletion. The serum sodium will improve slowly by approximately 1 milliequivalent for every liter of fluid infused. If the patient's serum sodium drops with IV saline, then most likely you're dealing with SIADH, which again, I would caution the use of saline in the clinical context of SIADH. So If you infuse normal saline in the presence of SIADH or patients with edema, the serum sodium will decrease and the patient's CNS symptoms will worsen. So in the case that I presented, the patient has hyponatremia due to antidepressant therapy, citalopram, and her urine indices clearly indicate that she has SIADH syndrome, and she was given 100 cc's of 3% normal saline as a bolus over 10 to 15 minutes, and a second bolus was repeated in order to improve her sodium, and her symptoms resolved when her serum sodium improved to 125. So what makes the diagnosis of SIADH? SIADH means you have excess antidiuretic hormone, which means that you will not be able to excrete free water and you will excrete sodium inappropriately. In the patient with SIADH, there is no evidence of dehydration or edema. Therefore, the serum BUN is always less than 10, and the uric acid is similarly very low. The urine indices are very important to notice that the urine sodium is inappropriately elevated in the presence of hyponatremia. And generally, the sodium in the urine will be greater than 20, and the urine osmolarity will be greater than plasma osmolarity. I often get confusion regarding urine indices because the lab values are in the report. So one cannot look at the lab values of what is normal. One has to interpret the urine indices, including the sodium and osmolarity, based on the clinical picture. If the patient has beer potomania or psychogenic polydipsia, the urine osmolarity will be low, whereas in SIADH, the urine osmolarity is very high. Again, there are many causes of increased ADH, and you must review all the medicine and stop the offending drug and make sure patient is not discharged on those drugs. I will now present a second case of a beer drinker with beer potomania. This is also very difficult patient to manage, and one has to pay close attention to this patient and admit them to the ICU. So here's a 52-year-old man with a history of heavy beer drinking, averaging 8 to 12 cans a day, who comes to the ER brought by his wife with 2 days of disorientation, confusion, tremors, weakness, and falling, and he is unable to go to work. His past medical history is he has been on low pressure 50 milligrams twice a day. He smokes 1 packet of cigarettes a day. And incidentally, 2 weeks prior to admission, he was prescribed hydrochlorothiazide 25 milligrams daily to be started for his hypertension as it was elevated in the clinic. Upon presentation to the emergency room, we found that the patient weighs 70 kilograms. He is quite confused. He is restless. He is unable to give any significant history of his alcohol use, and the history is provided by the wife. He is tremulous. His blood pressure is relatively stable. His mild tachycardia, his respiration rate and O2 stats are normal, and the initial serum chemistry shows that his sodium is markedly decreased at 106. His potassium is 2.5. His serum chloride is very low, 64. His BUN is 15. His serum osmolarity is 224. His blood sugar is 112. At this point, we obtain the urine osmolarity, which is 280. Urine sodium is 24. BUN is 15. And the magnesium is very low at 1.1. What is the appropriate management of this patient who clearly has significant hyponatremia and is at very high risk of complications from hyponatremia? The patient is initially given 1 liter of IV saline in the emergency room, and the hospitalist is consulted. 2 hours into the patient's ER visit, his serum sodium is now 104, and he is admitted to the ICU. He is immediately started on magnesium 4 grams IV, thiamine 500 milligrams IV, and Ativan 1 milligram per alcohol withdrawal recommendations. He is admitted to the ICU for close monitoring. The intensivist is consulted for further management of this patient. The patient was given immediate 3% hypertonic saline. The rule for correction of hyponatremia is that 2 cc's per kilo of hypertonic 3% saline will increase the serum sodium by only 2 milliequivalents. However, we also forget that every 3 cc's per kilogram of urine loss will also increase the sodium by 1 milliequivalent. This is the reason why patients overcorrect their serum sodium. It is not the hypertonic saline. I would like to stress again, 2 mils of hypertonic 3% saline can only increase the serum sodium by 2 milliequivalents. So this is not a reason to not give hypertonic saline, as this is not the cause of overcorrection. The usual cause of overcorrection of hyponatremia is excessive urine loss. And unless we monitor the patient's urine output by inserting a Foley or accurately collecting all his urine, then it is very easy for patients to overcorrect in this situation. So the diagnosis that we have here is hyponatremia due to beer potomania, as well as additional insult of hydrochlorothiazide causing significant fluid retention. The patient is treated with hypertonic saline over 10 minutes without a central line. Foley catheter is inserted. The repeat urine sodium is 108 in 4 hours. However, the nurse reports to the intensivist the patient's urine output is very significant, of 300 mils. Since he weighs 70 kilos, this is equivalent to serum sodium rising by another 2. So the question for the nurse is, would you continue to give another dose of 3% saline? The answer here would be that we would avoid giving further 3% saline, as the patient is at risk of overcorrection by aquapheresis or excessive diuresis once the alcohol or beer potomania resolves and the patient is taken off hydrochlorothiazide as well as alcohol. He will diurese over the next 24 hours. So the patient's serum sodium is monitored over the next 4 hours, and as predicted with the excessive urine output, the sodium has gone up to 112 and 116. So one now is concerned about what is called osmotic demyelination syndrome or pontine myelinosis. The question, therefore, is what causes this very serious neurological complication and how do you prevent it? In this situation, I would like to stress again, it is not the hypertonic saline, and there is frequent misconception by many physicians and staff that the hypertonic saline should be feared. What happens in this situation is the excessive urine output will cause the auto correction or overcorrection of serum sodium, as we are seeing in this patient with beer potomania and hydrochlorothiazide. So in order to stop the serum sodium from overcorrecting or excessive increase in serum sodium, we have to start the patient on desmopressin. I generally use 2 micrograms sub-Q or IV every 6 hours, and also add D5W, which will lower the serum sodium over the next 24 hours to the safe range and prevent overcorrection. This is reviewed very well in the New England Journal of Medicine, which looked at alcohol-induced hyponatremia, which occurs in 17% of patients presenting with hyponatremia. The risk of osmotic demyelination syndrome is increased by low serum potassium, low magnesium, low serum phosphate, and hypoxemia. Therefore, one must check the urine output hourly, and the nurse should report to the doctor if the urine output is over 200 or 300 cc's per hour, as the serum sodium will start to increase. So as we can see here, in beer potomania, there is increased release of vasopressin due to volume depletion, There's increased risk of osmotic demyelination with polypotomania. And we must restore the volume and increase protein intake and limit the rate of correction of sodium to 6 to 8 in the first 24 hours. In order to slow the rate, we must introduce 5% dextrose and desmopressin, or both. This again is a review by Stearns in New England Journal of Medicine in 2015. And they have carefully reviewed correction of severe hyponatremia. If the duration of hyponatremia is several hours, such as self-induced water intoxication, running in marathons, or ecstasy use, excessive correction is not known to be harmful, and 100 cc's of 3% saline times 3 as needed for symptoms should be utilized immediately. And again, serum sodium should be corrected by 4 to 6 in the first 6 hours. If the patient's serum sodium has been unknown or greater than 2 days, as in our case with the polypotomania, this is a high risk of osmotic demyelination. Plasma sodium concentration is less than 105. The patient has hypokalemia, alcoholism, malnutrition, and liver disease. They present with malaise, fatigue, confusion, cramps, and falling. There's a risk of seizures, especially when the serum sodium is less than 110. Extra caution is indicated in these patients for risk of osmotic demyelination, and 100 cc's of hypertonic saline should be administered for seizures or altered mental status, and again, hope to increase the serum sodium by 4 to 6 in the first 24 hours. Avoid increasing serum sodium by greater than 8, and consider lowering it again with the use of desmopressin. The risk factors for hyponatremic encephalopathy are higher if the patient's acute hyponatremia is less than 48 hours, if the patient's age is less than 16. Female patients, which cause further risk factors, and also hypoxemia. So administer supplemental oxygen and elevate the head of the bed. Osmotic demyelination syndrome of central pontine myelinosis is a rare disorder. It causes spastic tetraparesis, pseudobulbar paralysis, including dysphagia, dysarthria, swallowing difficulties, emotional lability, and eventually large central pontine lesion may cause the locked-in syndrome. Usually, the myelinosis occurs in the pontine level, although there have been reports of demyelination syndrome, including the cortex as well. The treatment of hyponatremic encephalopathy in the critically ill patient was reviewed in this excellent review in Critical Care Medicine, October 2017. I encourage everybody to read this article. It clearly recommends this is a life-threatening disorder, and 100 cc's per hour can be given safely. It is critical to recognize early signs of cerebral edema, including nausea, vomiting, and headache, which we tend to ignore, and intervene with IV 3% hypertonic saline rather than waiting until more severe symptoms develop. Cerebral demyelination is a rare complication. So the management of patients with SIADH or patients with excessive vasopressin is to discontinue first all the offending medicines, obtain an excellent history on their use of alcohol, as well as water intake. Check for any CNS pathology by obtaining a CT scan of the brain. Obtain a chest X-ray, rule out malignancy or COPD. Initially, patients should be started on fluid restriction, and I stress again to avoid starting IV saline in the emergency room, as this may cause further problems. The patient should be admitted to the ICU for close monitoring of their serum sodium every 2 to 4 hours, as well as monitoring the urine output for excessive diuresis, which will cause overcorrection. There is no role for Vaptans in the guidelines in USA, Canada, or Europe, as this may cause acute overcorrection of hyponatremia. The patient's fluid restriction is based on the urine potassium. This is called the first formula, and this will tell you how much to restrict the patient's water intake. Generally, patients' fluid restriction should be 1 to 1.5 liters per day. So the management of hyponatremia, again, is reviewed very nicely in this New England Journal of Medicine article by Stearns, who is an authority in this area. It is clearly a medical emergency. A rapid drop in serum sodium will lead to neurological symptoms, including headaches, vomiting, falls, cramps, unsteady gait, possible seizures. And when these patients are seen in the emergency room, one must check the urine sodium and osmolarity stat in order to proceed further. If the patient has SIADH, one must use hypertonic saline early. There is no need for a central line, as many protocols dictate. This is not true. The patient should be given IV hypertonic saline over 10 minutes to 15 minutes, which will raise the serum sodium by 2 milliequivalents. This may be repeated to a total of 3 boluses if the patient still has symptoms. The patient should have serum sodium checked within 2 to 3 hours. Avoid overcorrection of 8 to 10 milliequivalents in the next 24 hours, which also requires ICU admission. And monitor urine output is absolutely essential. If the patient cannot cooperate, I would recommend placing a Foley only for 24 hours, because that is usually the danger period. The patient's serum sodium should be corrected to 120 milliequivalents initially or until symptoms get better. Generally, increase the serum sodium by 4 to 6 is adequate to control the patient's neurological symptoms. Please do not give Haldol to these patients, as the patient is at risk of having further hyponatremia and seizures with Haldol. Use desmopressin early, 1 to 2 micrograms IV or sub-Q, and add D5W infusion in order to prevent excessive correction, which, as I've mentioned, occurs with beer potomania, psychogenic polydipsia, and patients who've been on diuretics, including hydrochlorothiazide, which is very common. Thank you for your time and attention.